Alrighty, so this video probably won't be as like fun with little video effects and stuff from my new little video editing software or whatever. I just don't have time for it right now. Wanted to get this video out rather quickly just because I had a patient who had a problem recently that can happen to many people, but it is rather rare in and of itself. However, it can happen to transmasculine, transfeminine individuals, so whether you're on T or E, doesn't matter. Estrogen and testosterone both can cause this to happen. So let's talk about lactation. So obviously lactation is going to be a little bit more disturbing probably for our transmasculine individuals, for them to have that happen whenever they're on testosterone, because one would think you're on testosterone, you wouldn't lactate. So, one thing to be aware of, like, there's different degrees here of lactation. Like, there's like, oh, there's a little drop from the nipple. Maybe clear white to white colored is usually the norm for that. If it's anything like gray or green or funky smelling or something, you know, like something rotten, okay, that's a different thing. That's not lactation. That's probably that you've got some kind of an abscess or an infection somewhere in the chest itself or nipple itself. So that needs to get checked out like ASAP. But in regards to just like a milky white or clear substance being emitted from the nipple, that's more along the lines of, you know, normal. Maybe not the normal that anyone wants, but it can happen. So anyways, whenever you see this, number one, you know, want to make sure you make note of the color, the consistency, and the amount, and the timing of the day, what you were doing whenever it happened. That way you can let us know as the healthcare provider, so we can kind of see, is this something that could, you know, potentially snowball and get worse? Is it something that's just like a rare, like, oh, okay, it was just like one or two times and it's going to go away on its own, you know, something like that. So make note of those things just so that you can report them to your healthcare provider. And by the way, this lactation can be caused by other various medications, you know, just there's all kinds. I mean, honestly, like, I can't just list them all. If you just Google how many medications can have a side effect of causing lactation, or in the medical society we call it galactorrhea. Fun name, whatever. We make up all these names just to make ourselves feel special here in medicine. But anyway, so anything that causes lactation or galactorrhea out there, you can look up, big old list of them. Doesn't mean that if you're on it, it will happen, but it is a rare side effect of some medicines, as well as being on hormonal medicines. So anyways, what's the cause? Sometimes it's hard to determine the cause. In hormone therapy, it's usually going to be caused from estrogen levels, because estrogen is going to help stimulate the production of prolactin, and prolactin is, as it sounds, prolactin. It can help promote lactation. And levels of hormone in the body, or hormone, Jesus Christ, anyway, levels of estrogen in the body can be the cause of this. And so where does that come in for those who are on testosterone? I mean, obviously we figure if someone's on estrogen, obviously that raises their estrogen levels, but where does that come into play with testosterone? So as you might have known through some of my other videos, if you've watched them, there is a process called aromatization in the body, and that is where aromatase causes the conversion of testosterone into different forms of estrogen. All the hormones in the body like to convert into different hormones, so it's always a fun time trying to figure out what's going on with the endocrine system and everything when it comes to sex hormones. But anyway, so testosterone can convert into different forms of estrogen. Normally this happens whenever your body senses that testosterone levels are too high. And what's too high? Well, it can be different for everybody. So I can't just tell you, oh, okay, definitely if you go above whatever 900 of a total testosterone level, well then you're for sure gonna aromatize that T into E. Not necessarily. So it could be 1200 for other individuals. It could be a little bit higher than that. I mean, it really, like, each person is going to have a different set point in their body that your body considers to be the homeostasis maintaining hormone levels. And so I can't tell you an exact number, but if your hormone levels, testosterone in particular, are trending a little bit on the high side for your body, then it will usually try to convert some of that. Now, that being said, sometimes that happens anyway. because I mean that is the body's main way of getting a hold of some estrogen for itself, and everybody needs estrogen. You know, you need both T and E, everybody, whether you're Femme or Masc, for bone health, brain health, and all these other bodily functions that we do so love. Anyway, and so you're going to need some conversion. And so sometimes whenever you're introducing these large doses of testosterone all at once in one injection, say weekly, then your body can go, whoa, this is a whole lot all at once. Let me just kind of utilize this and change it over into some E. And so anyways, so you can get galactorrhea or lactation from the higher testosterone levels being converted into estrogens, which then can turn on the production of prolactin. Anyways, that's one of the main processes that we see in hormone medicine anyway. There are tons of different processes that can cause this problem, but here in trans medicine, this is where we live. Anyways, this is usually not that big of a concern, like I said, for the trans ladies. If it happens, it can be annoying because then you got to change out your shirt or your bra if you got a lot of it. And usually if it's a problem for you and you want it to stop, what we usually do is back down on your estrogen levels a little bit and see if maybe that is what the problem is. And that's usually it, is just your body's set point for estrogen being a prolactin stimulator is being triggered by a certain level of estrogen. And so we just try and slowly drop your level of estrogen just till we hit that set point and we get underneath it and you're no longer having that problem. Usually that problem is going to be short-lived though, even if you just, grit your teeth and get through it. It's usually going to be something that resolves, but it also can continue going. So at that point, that's where you say, okay, is this annoying enough to where I need it to stop? Which for most people it is, but some people just don't care, especially, like I said, the trans femme individuals are like, all right, that's pretty cool, all right. But my trans dudes and trans masculine individuals, they're usually not as keen on that. So anyways, what we do for them is a little bit different. Usually the first step is to reduce your testosterone dose, whether we check your labs and your T level is high or not. I mean, obviously if we check your labs and your T level is, higher than maybe where, it should be. Like I said, if I check your trough level, your low level, like 7 days after your shot, and it's like 900, if you're having galactorrhea or lactation, I can bet it's because your T level is way higher during the week. Anyways, but if your T levels have been perfectly fine, well within, what is considered normal range, then I'm still probably going to recommend a slight reduction in T dosage, and it's not going to be a huge reduction. Like, we're not talking like, oh my God, I'm going to cut you down to 25%. Nothing like that. Like, we're going to walk you back like 20-25% maybe, and see how you feel, see if that resolves it. And usually that's going to take a few injection cycles to really work in there, because the half-life of testosterone is generally about 7 days, depending on the type you take, cypionate, versus enanthate versus the other kinds. Anyways, the kind I'm talking about generally is going to be a 7-day half-life, and so that means that you need about 4 injection cycles before you reach a steady state. So I give it about 3 to 6 weeks and see if that does resolve that problem. If not, we can also talk about walking it back further. Depends on how you're feeling at that time, because some people don't feel that great backing it down. And some people's dysphoria might just be going through the roof thinking that they're getting reduced. It just, like I said, it depends on the person. Now, there are other medicines that can help with this problem. I usually reserve them as the second step, just because the more medicine you take, then the more medicine you take, and then you're looking at, potential other side effects and blah, blah. I mean, it's more expense, it's more potential side effects and all that. And if you can avoid all this just by walking back your T dose just a hair, me personally, I would prefer that. But if a person tells me, nah, that's just not an option for me, my levels have been fine and I don't want to walk it back, that's fine also. We can start off with step 1 being the aromatase inhibitors. And remember earlier I said that aromatase is what is responsible for helping testosterone aromatize. into estrogen. So you take this aromatase inhibitor such as Anastrozole, also known as Arimidex as its brand name, but Anastrozole is how I prescribe it because it's cheaper as a generic. But anyway, you take this aromatase inhibitor. Usually I start you off once a day for about a week, and then you go to every other day. And we see, does this stop it? Generally speaking, if the problem is the hormone stuff and not some other conundrum like another medicine you're on or something, this is usually going to stop it within that first, usually it'll stop it within the first few days that you're on it, but every now and then we'll have somebody that it takes them that first full week into the second week or so before it slows down. But anyway, so you can go on that, and usually it's temporary. You don't have to stay on it, permanently or anything. It's just we figure out, okay, so that was the cause. We talk about your dose and everything with testosterone, see if there's something we can work with there. Anyways, and just kind of go from there. Like I said, everybody's going to be different in, how they want to go about this, what they're comfortable with. And I'm always open to talking about, what the patient wants and how they're feeling and everything. Because you never want to just make the whole 100% decision for the patient. Wink. Any healthcare providers out there listening, please don't do that. Just, educate, make your recommendation, and as long as whatever it is that, the patient is wanting to do isn't going to hurt them, even if it's not specifically what you want them to do, let them go ahead. Even if you think, oh, well, it's not going to work, just tell them, okay, I feel like this is the least effective route that you're going to be going, but there's always this other thing over here that I recommended in case this doesn't work. So just be aware that we also have another option, and let them go. Just let them do what they're more comfortable with, because sometimes it just takes a little time for them to come to the realization that maybe they needed to do the other one or whatever. Not a big deal. They're not challenging you. Anyway, sorry to get on that soapbox. I just also had another annoying experience where somebody apparently was lecturing a patient of mine about stuff that they didn't really know anything about. And so my patient's just okay, they don't know what they're talking about, and they're sitting here lecturing me. This is great. Anyways, moving on. So to sum up, lactation or galactorrhea can happen in trans femme or trans masculine individuals. There are different ways of managing it. The usual way with trans feminine individuals is to watch and wait. And then if it is maintaining as a problem, then you can back down on estrogen dose. And also you should be investigating, is there some kind of other medical anomaly in here, such as more commonly medications that could be causing this, or at least adding to or exacerbating the problem. And then with the transmasculine individuals, watching and waiting is usually not what they want to do, but it is an option. And then, like I said, my first go-to option is usually going to be reducing the testosterone dose, so that we then thereby reduce the amount of estrogen that testosterone is converting over into. But that is a slower step. Another alternative is you can do more micro dosing with testosterone and do either every other day or every third day subcutaneous injections with testosterone. This does help with the conversion rate of testosterone into estrogens. Like I said, it's just another option. There's a lot of them out there. I just don't want to take up 10 billion years of your time talking about this, because I've already taken up enough. Anyways, and then if that doesn't work, or if the patient's just not comfortable doing that because it's going to take way too long for them to get results, and they're just already freaking out about the lactation, then we can go with an aromatase inhibitor such as Anastrozole and start that off. Like I said, usually I'll start it off with once a day for a week or so. And then go to every other day, and then we'll talk about, after they've been on it for about 3 or 4 weeks, then we kind of talk about, let's see if we can taper off of it. Some people are very uncomfortable and they want to stay on it for even longer. And usually at that point I'll do either every other day or every third day for Anastrozole, because it has a very long half-life. So you don't necessarily have to take it every single day. But anywho's, so hopefully some people out there that may experience this in the future will not have such a freak out whenever they encounter it, because even though it is a fairly rare side effect, it is something that's it's just hormones, and this stuff can happen. Like I said, like trans guys those are usually the ones that get hit the hardest with it dysphoria wise, but let me tell you, cis guys that get on testosterone, this happens to them too. This is not just because, you know, you have some different part of anatomy that you came with into testosterone therapy and that's why it's happening. Like, that's not it at all. This just happens. Like, literally, if you have a trans dude who has undergone chest surgery and so they've got a masculinized chest at this point, and that's great, but that can still happen to them because it's just the type of tissue that's in that area. And cis guys experience that as well whenever they go on testosterone replacement therapy. So it's just fun times for everybody. Like I said, Femme, Masc, don't matter. We're all here lactating. Anyway, I'll see y'all later. Hope that helped somebody. Bye.